First of all, thank Dr. Khanna for giving me opportunity to speak on this topic. I'll just present a small case with a movie for some learning points to the beginners for how to do these retrograde recanalizations. For many years, the classic approach to PAD has been open surgery, but with the advent of endovascular surgery, it has been a dramatic shift in the treatment plan, and innovations in higher resolution imaging, lower profile systems, stent technologies, dedicated peripheral balloons, and catheters have resulted in better outcome. I'll present you one of the case who was a 65-year-old male. He was hypertensive, hyperlipidemic, chronic smoker, diabetic, who had peripheral artery disease, Rutherford category 5, present with rest pain in left foot. His left growth toe was already amputated with a non-healing wound, and second toe was also gangrenous. With it, angioplasty with stent to the other side, right SFA and balloon angioplasty for right ATA last year. And at the same time, we attempted angioplasty on left infrapopliteal arteries, but we were not able to recanalize from anti-kit approach, and I will show you why. This is the angiogram showing that the femoropopliteal segment was pretty clean. So then we used a 45 centimeter sheath, and then we took angiogram, and we can see that there is a complete blockade at popliteal traffication, antitibial artery, TB trunk, posterior artery, all are occluded. It's all collateralized. So we tried to go from above, but we were never able to get into the true lumen of posterior artery or peroneal artery from above. I'll show you the distal runoff. This is the reformation of PTA in mid-leg level. ATA is still not showing any flow. And this is the runoff at the ankle. Posterior tibial artery is pretty good. Anterior artery is still just at the ankle, it is reforming, and then it is a PTA, which is predominant artery supplying to the foot. So we plan to puncture posterior artery at the ankle and then go upward with the support of balloon in order to recanalize it. So we used a sheathless transpedal access, in which we use a micropuncture needle from Cook. It is 21 gauge, 4 centimeter needle, 7 centimeter needle required when we have to puncture peroneal artery. We can puncture it under a Doppler guidance or a fluoro guidance, fluoro road map, or just by seeing calcification of the artery. We use over the wire balloon with an outer diameter of 2.8 French, tracking over O14 or a A18 guide wire. So in this technique, we're not using any sheath, although 3 French sheaths are now available in the market which can be used. But we can also do it without any sheath, just pass balloon through the skin over the wire. The advantage is that it decreases the size of distal arterial puncture hole. So we cross the artery with a balloon over the wire, and then we took multiple shoots all along the way to see that we are remaining into the true intraluminal plane. So we used a 2 into 100 size balloon over the wire, over a V18 wire, in order to cross it from the retrograde plane. And just checking multiple shoots all along the way, so that just to ensure that we are in true lumen. So we have just reached up to the origin of PTA, or the distal part of TB trunk, which then we recanalized, and now we have entered into the popliteal artery. So now this is the angiogram that we finally obtained after recanalization. And then the way is to thread this wire across the catheter and bring out the wire end from the groin. So the snaring of the retrograde wire can be either done with a snare or with a catheter with a small angle with a tip across the arterial wall, and then we recanalize with the support of the arterial wall and the guide the wire through the catheter. Now we have both ends of the wire at upper and lower leg, and then we remove the balloon from the lower end. From the top end, we introduce the balloon till the distal arterial puncture site, remove the wire, and then introduce the soft end of the wire from above and then do all the procedure from above. We use 3 into 100 millimeter balloon at top and 2 into 100 in distal part. And this is the final angiogram that we obtained with good flow across the TP trunk into PTA with a good runoff, no contrast hold up. And this, I just want to show you the distal runoff was significant. The patient has been in follow-up. This case was done almost 15 minutes back, and now the patient still came to me last month back with a good postoperative pulse. All his wounds are healed and is in a working state. So just wanted to conclude by saying that retrograde approach for tibial occlusions is a valuable technique if an antegrade recanalization attempt fails. The technique is safe regarding the puncture site of the distal artery. Of course, we have to provide compression for almost 20-30 minutes at the distal artery puncture site and make sure that there is no leak before we come out of the cath lab. The clinical success is very acceptable and supports the use of this technique. Thank you.
Thank you. That was a very fine case presentation. There's a fellow by the name of Craig Walker, who's from Houma, Louisiana, who has done many of these, and he's a big proponent of the pedal access. He makes some good points, which you pointed out, and that is to put the balloon in bareback without using a sheath in many instances, keep the puncture site small. And he's been his data looks very good from that. I think probably a much better way than trying to come from above and get through vessels that are very difficult to get through.
Sure.
Sir, I would like to add something to what Professor Buckley just said. Yes, Greg Walker was a pioneer, and also the people from Leipzig, Andre Schmidt and Dick Scheiner. Maybe you went there?
Yes.
Have you been trained by them?
No, I've seen a lot of his videos. It's
But
very
as a reminder, because this is a fellow course, this is not easy technique.
Yes.
You need to be trained, you need a learning curve, you need to go to workshop and see these people working. They do 10, 20 a day. So if you want to start, you need a good imaging system in your room, you need a good skill, and you need good stuff in your room, because O14Y is 100 or 200 euro, and maybe sometime you need 2 or 3.
Yes.
So for the fellow in the room, you have to learn the technique and learn from a master and look at him during several days or weeks. Michel, comments?
I don't have any more comments, but I totally agree. It's a difficult technique, but beautiful technique and very useful, because if you have failure by antegrade approach, a unique way is this way. And so you can enlarge indication and avoid femtibial bypass, distal bypass, and we know the result of distal bypass. So yes, congratulations. That's good.
Thank you. Thank you.